I can start talking to them before they say that. Good afternoon, colleagues, those online and those in person at our fourth CPD organized by the Society of Family Physicians of Ghana. We must say we are elated to be bringing this series as we gear up for our AGSM coming up from 21st to 24th May. Like I mentioned before, you're all welcome to this afternoon session. We will want to reflect on what we have been doing for the past 2 weeks. Our first CPD was on urinary tract infections. We proceeded to also have a CPD on the management of diabetes. On Tuesday, we had an insightful session where we discussed the management of asthma in primary care. Today's session, we are going to talk about practical updates in the management of hypertension in primary care. We all agree that as we sit at our OPDs, hypertension take up a lot of our patient numbers. So we want to be able to be well equipped so that we can take care of our patients. Without wasting much time, I'll call on Dr. Kajepo to give us the opening prayer.
Thank you very much. Shall we pray? Our Heavenly Father, we thank you for this day. We thank you for the opportunity to gather and learn. We commit ourselves into your hands. Spirit of God, as we are about to proceed, we pray that you take absolute control over everything that we'll do here, that we will leave here giving you all the glory. In Jesus' name we pray with thanksgiving. Amen.
Amen. Thank you so much, Doc. It's a privilege this afternoon to have experienced speakers joining us to share valuable insights in current guidelines and treatment strategies in managing patients with hypertension, as well as how we can reduce long-term risk in these patients. Thank you for making time to be here. I encourage you to be active. If you have any questions, you can put it in the Q&A box. We'll try to answer them by typing or actually reading out the question and answering them. So feel free to participate and post your comments and questions in the Q&A box. So we box on. Our first speaker is somebody that I'm really excited to introduce. He's a family physician, trainer, and a healthcare leader with extensive experience in primary care, hypertension management, preventive medicine, and health system strengthening. He's currently serves as the head of the Polyclinic Family Medicine Department of Kolebu Teaching Hospital, and is a fellow of both Ghana College and West Africa College of Physicians. And beyond that, he has contributed significantly to the development of Ghana's cardiovascular guidelines, among other things. He remains passionate about improving healthcare outcomes in primary care. Dr. George Nketia, as you may have guessed already, is also our immediate past president of the Society of Family Physicians of Ghana. So he's at home this afternoon. So kindly join me warmly welcome Dr. George Nketia as he takes us through updated hypertension guidelines and initial treatment strategies.
Thank you very much, our Honorable President, for your kind introduction, and thanks for the privilege and the opportunity to speak today on this topic. A very important topic because, as I said, is actually the #1 cause of cardiovascular events in the country and worldwide as well. And I'm sure that if we're able to get it right, then most likely we should be able to reduce our mortalities as well. So my objective this morning will be to help us at the end be able to define and appropriately classify hypertension, to understand the causes of hypertension, measure blood pressure correctly, diagnose hypertension correctly, understand the initial management of hypertension correctly, and to detect early the complications of hypertension. Why hypertension and why does it matter in our case? It's good to know that it's the leading global risk factor for cardiovascular diseases and premature death, as I said. And we know that most of these cardiovascular deaths are in the low to middle income country. And I always say that our beloved country, Ghana, is part of these countries. It's a major contributor of stroke. And I'm sure that when you hear of stroke, heart failure, chronic kidney disease, everybody is scared. But indeed, it's a major contributor. And I think I should be confident to say that the #1 cause as well. The problem is that it's often asymptomatic, resulting in delayed diagnosis. Of course, if somebody is known to have hypertension without any symptoms, it's difficult to convince them that they have a condition and they have to get treated. But early detection and sustained control really significantly reduce morbidity and mortality, and we need to be able to do that as well. We need to always know and also communicate to our clients that hypertension cannot be cured, but requires lifetime management. What's the global burden? Approximately 1 in 3 adults, according to the WHO 2025, actually, aged between 30 and 79 years have hypertension. That's a huge number, 1 in 3. 2 out of every 3 people with hypertension live in low to middle income country. And that makes it even more scary. It means that in an environment, most of these group of patients are here. What about Ghana? Work that was done, I think 2021 by BOSU, showed that 1 in 4, about 1 in 4, a little more than 1 in 4 adults live with hypertension. Only 35% of this group are aware of their status. So when you go to the street, you get, let's say 4 people, 1 definitely may have hypertension if they are between 30 and 79. And of all this group of people who want, only 35% of them are aware of their status. And even more scary, only 22% are on treatment. And even to make it worse, only 6% of these have their blood pressures controlled. It means that most of the people do not know, and even those who know, their BPs are not controlled. We have a long way to go. We have a lot of work to do as a team. By definition, hypertension is said to be office, and the word is office systolic blood pressure values more than 140 millimeters of mercury, and diastolic blood pressure more than 90 millimeters of mercury. I'm using office because as we go on, you come to realize that we can use other means to diagnose, which will not be of this level, but most of the hypertension cases will be diagnosed at the clinics. And at the clinic, we are looking at 140 or 90. But the current cardiovascular guidelines, the targets for hypertension has not changed. This definition actually applies to those who are more than 18 and those who are for diagnosis. There are some phenotypes that I want to talk about, which we see at the clinic a lot of times. One is the white coat or isolated chronic hypertension, and this is where the person's BP is persistently elevated when measured in the clinic. But normally at home, they bring their readings and they're fine. Or when they measure it outside the clinic setting, they are fine. I mean, these are people who probably in the hospital environment get anxious, and actually with that would increase their BPs. We also have the masked isolated ambulatory hypertension. For the masked one, this is where the BPs are normal at the office setting at the clinic, but elevated when measured out of office. And this is quite a difficult one because they come to the clinic and they are fine. You check it, they are fine. But you actually do some investigations and you realize that they're actually having hypertensive-mediated organ damages. They may have left ventricular hypertrophy. They may have some issues that they think that is because of these blood pressures. But at the clinics, you measure it and the BPs are normally normal at the clinics. And these are the ones that if you have the ambulatory BP measurement or the home BP measurement, you can have it to help you diagnose. We also have the nocturnal hypertension. Typically, there's a dipping of BPs during the night. It's a circadian set up where when you sleep, of course, autoregulation at that time, the sympathetics take place and your BPs actually dip, sometimes between 10 and 15, 20%. But there are some people that there's no dip. Okay, so they're non-dipping. So for those people, their BPs are actually very high when they are sleeping beyond 120 on 70. And of course, if the BPs are high beyond those levels, then it's going to affect them the same way that somebody's BP will be high over a long period. But these people, normally during the day at home, their BPs will be below 135 on 85. So typically at night, and these people, you definitely will have to do the ambulatory, to know. So there's also the nocturnal hypertension, which we need to know. Then the resistant hypertension, where there's failure to control the blood pressure when a client is on 3 or more antihypertensives. Typically, we see that including a diuretic. So if the client is on at least 3 antihypertensives, typically including a diuretic, and you are not able to control, you are finding difficulty, then we would say it's a resistant hypertension. And I'm sure my dear sister will take us through that a lot. Now let's come to a lot of changes that have come through and some reasons behind it. So if you look at the cardiovascular guidelines, the first one that was done 2019, we had the classifications being optimal, normal, then high, normal, then we had hypertension grade 1, grade 2, grade 3. In the European Society of Hypertension Guidelines, 2023, they maintained it, but 2024, European ESC, the cardiology, Society of Cardiology, it has changed a little bit. So when you have, we have the non-elevated, where we are looking at BPs, systolic BPs that are less than 120. Previously, we would have said optimal. Then beyond 120 to 139, we say it's elevated. It's elevated because we found out that at that level, some people definitely, what affects them. And there's now guidelines that for those who have elevated, you need to pay a close look at them. And so we have now patient-centered guidelines to help these people. So somebody with elevated BPs, you don't just leave them. So they start their lifestyle. And if their cardiovascular risk is high, then you need to discuss and consider actually starting some treatment. So those with elevated, we do not just leave them. You have to consider, look at their cardiovascular risk. If it's high, then you may need to consider actually putting them on treatment. And now there are grade 1, grade 2, grade 3 has actually been taken off so that people can concentrate on early control of the BPs and urgent ones. So when it comes to the home BP measurements, as well as the 24-hour BP measurements, it has also changed. Of course, if the 24-hour BP measurement is between 115, systolic 115 to 129, then we are looking at elevated. If the home BP is between 120 to 134, then we are looking at elevated. And for the ambulatory 130 or more, and the home BP average of 135 or more, we are looking at hypertension. Going to the diastolic is also been categorized like that, non-elevated. If you are looking at the office one below 70, 70 to 79, 70 to 89, we are looking at elevated. Then 90 or more, we are looking at hypertension. It's good to know these ones so that we disabuse our minds of the old ones so that we can be patient-centered, and those who have elevated, we can start working on them early. What's the etiology? So for primary, so we are looking at mainly primary and secondary for hypertension. Primary, we're looking at mostly multifactorial. There's no specific underlying cause, but it's been realized that these are reasons driven by lifestyle behaviors such as excess salt, insufficient potassium intake, inadequate physical activity, overweight, and the like. And it's good to know that about 90% of all hypertension are actually due to primary hypertension. For secondary, we have underlying causes. So identifiable underlying causes, and they account for 10%. We look at a few of the risk factors when it comes to the primary or the essential. There are some that are modifiable, some that are not modifiable. I always tell people that you cannot change your age. God is my good friend. I've tried, but never got that opportunity. And I'm not sure that he would change your age. Race, if you are born to a Black parent and you are taking the US, it doesn't change your race. Family history, if your parents are known to have hypertension or some other conditions, and let's say you're even adopted, it does not change it. So these are things that you may not be able to change, but it's good to let our clients know that these are major risk factors you cannot change, but so far as they are there, you need to be very conscious of it and know that these are going to increase your risk of having hypertension, and you need to work on your lifestyle even better. There are some that are modifiable, which if you work on, you could delay probably you having hypertension. Is a preventive measure. So these are risk factors that we need to know and deal with. So overweight and central obesity, sedentary lifestyle, smoking, high salt intake, low potassium, low vitamin. I'm sure we all know all these things, but I'm just stressing them again so that we'll be looking out for some of these things whilst we see our clients. Sleep apnea is there, stress from our work, long-term cancer survivals. All these are risk factors for primary hypertension. For the secondary hypertension, just grouping them, the most common ones, the chronic kidney diseases, obstructive sleep apnea, the Cone syndrome, the thyroid disease, some of the medications. But for this one, I'm sure when you get a slice, you can take a look at them. But I've categorized them, and it's good to know that we can have the renal pericardial diseases where chronic glomerulonephritis, adult polycystic kidneys, all of them could lead to that and could lead to secondary hypertension. Normally, you will see periorbital edema for these ones. They may have nocturia, generalized body swelling, anemia. Can also have renal artery diseases where on your examination, you could pick up a renal artery blue and could point out to it. For the endocrine, there are a number of them: the Cone syndrome, the Cushing syndrome, the pheochromocytoma, the thyroid disease, the acromegaly, the hyperthyroid disease, the adrenal hyperplasia. All these are specific underlying causes. And if you're able to pick them and work on them, of course, then you're going to be able to deal with the blood pressures. Cardiovascular, we have the aortic coarctations, where you have your radiofemoral delay and brew. I hope that we examine our clients, especially when we see some of these things to pick. I wish I had some people to ask when was the last time they did a radiofemoral delay during the examinations. But these are things that will help us to pick certain things. And if you think that's a cardiovascular case, sometimes you need to do a full examination to pick up some of these things. Medications, oral contraceptives, steroids, vasopressors, NSAIDs are corporate for some of these things. And obstructive sleep apnea, which these days is becoming a lot. These are people who have apneic attacks during sleep and daytime sleepiness and snoring. And if you have these things and the BPs are high, you need to go further and try to see if these are the underlying causes of those. For clinical presentations, as I said, most of the time you're going to have asymptomatic patients, but occasionally they may present with palpitations, headaches, breathlessness, of course, chest pains, dizziness, easy fatigability, and the others. But most of the time, you're going to have clients who are asymptomatic, and that's actually what makes it quite difficult convincing clients who are known to have hypertension to be on medications. Other features of interest that per your assessment and when you're assessing, you really need to take note that have been stressed in the guidelines is the time of the first diagnosis of hypertension, including records of any previous medical screening or hospitalization. It helps you to know, how far they've come, whether they've been compliant, whether they have had severe issues, whether they are stable, and whether they have rapidly increasing BP. So some people may have it and rapidly it's increasing. You need to check all those ones. Recording current and past BP values. So there are clients who will come and over the years, they've actually recorded their BPs at home and at hospital. They have a book. You need to ask of that. And if they have, it helps you instantly to know per your averages whether indeed they actually have it or not. Current and past antihypertensives, medications, including their effectiveness and intolerance. Their clients nobody really paid attention to. And it's good to ask when you have clients so that if there are issues in terms of compliance, you can pick it up early and deal with this. I don't want to tell people for previous hypertension in pregnancy and preeclampsia, you may also want to look at those ones. Drugs that typically may predispose, we've talked about them. Paracetamol, though it's not, but if somebody is on it for a long period, it may. Immunosuppressive drugs, anti-cancer drugs, nasal vasoconstrictors, all these things you need to ask about it. For clinical presentation, some observed signs are usually due to the underlying pathology, and you need to, for your examination, be able to pick them up, or they may be due to complications of the hypertension. And a lot of times when you had a client who is not to have hypertension, please check for the APSB, because they may have an enlarged that you've not seen it. A lot of time we just see them and we check the BP, they are high, we write medications, we are gone. Do you know that this client probably had some complications already, some end organ damage already? You will need to examine, at least check for your apex beat. Check for renal bulb, because it may be because of renovascular hypertension, as we've said. Check for your radiofemoral delay. It may be because of coarctation of aorta. And as I said, we need to be examining. We've come to a stage where a lot of the doctors and a lot of our colleagues are not examining. And I want to use this to plead that when you see clients, especially for the first time, try to do a thorough examination and document. Third heart sounds may be due to a heart failure. Fourth heart sound, hypertensive heart disease, and you need to be looking at it. For fundoscopy, a lot of people would say that it's difficult, but at least if you cannot do it, refer so that they can have this done and they can look at their back of eye to see whether there are changes already. These things may help you to know how advanced or how long even this condition may have gone on. For diagnosis, we always will see that screen every patient visiting the health facility to detect elevated blood pressure early. It's one thing that has been pushed in the guidelines and one thing that has been put in policy, that any client that comes to you, adult, for the first time visiting, please check the blood pressures. When you check, it may be high, but try to confirm suspected hypertension. We've already told you that there is white coat hypertension, and you may check somebody with BPs are, let's say, 150, 155, but it may be just a white coat and may not be somebody who really, so you may need to repeat the measurements, or you could do out of clinic measurements. Ambulatory BP measurements, a few places will have the machines, but the home BP measurements, if you have a good and validated monitors at home, is equally good. And a lot of people have been using it, and it's also recommended that we actually will use it when we don't have the ambulatory BP machines. For the diagnostic cutoffs, and this is where I think that I would want us to take a very close look at. For the clinic or office BPs, per the guidelines, we normally go with the ESH and the country's cardiovascular guidelines. If it's more than 140 systolic and or 190 or 90 diastolic, then it is hypertension. That is the office BP readings. If you are doing ambulatory, we can have the night time if it's checking for you and gives you a nighttime averages, and we have more than 120 on 70. It is hypertension. That's the nocturnal hypertension. During the day, if you have 135 on 85, it is diagnostic of hypertension. And if it does the average for you and you're having more than 130, more than 80 diastolic, then it is hypertension. If you are doing your home BP reading, so you've asked the client to do, let's say, a week BP readings in the morning and evenings, you get this, values that if recorded, and all you have to do is to find an average of this. For the average of these BPs, if it's more than 135, equal to or more than 135 on systolic, then it is diagnostic. If the average of the diastolic is more than 85, equal to or more than 85, then it is diagnostic. So if they are doing the home BP measurements, the cutoff is not the same as doing the office BP measurements. It is a little lower. You need to find the average and use that one to diagnose. One of the things that I think we need to go through, especially as primary care physicians, and also to teach our nurses who do this, is the BP measurement. So I decided to just bring it in because a lot of times you look at how people are checking their BPs and they are giving us wrong results, and you may be tempted to use that one to make decisions. And even if you are sending your client home to take the BPs at home, they need to know how to do it. So patients should sit comfortably at least 3 to 5 minutes before BP measurements, except in emergency cases. It's not when somebody has come with hypertensive emergency and you are asking the client to go and wait for 3 minutes. In emergency cases, you ignore that. But I mean, if it's not emergency, let them sit at least for 3 to 5 minutes. The systolic blood pressure measurement should be initially measured by palpating the radial pulse to avoid missing auscultatory gap. Of course, when you have irregular heartbeats, the automatic one may not be the best. And it's one of the reasons why we may need to check for the radial pulse, because if it's irregular, like atrial fibrillation and all that, then you may need a hybrid manual to do it, or a manual to be able to check. If you don't have, then it means that you may need to do repeated measurements to find the average. Take the 3 BP measurements, 1 to 2 minutes apart. Additional measurements should be performed if the first 2 readings differ by more than 10 millimeters of mercury, and the patient's BP, it will be the average of the last 2 readings. So typically you have to take about 3 readings. The last 2 is what you take the average of. Time may not permit you, you can do to find the average. But of course, if the difference between the 2 is more than 10, then you need to actually try to do a 3. At the patient's first visit, it's good to measure the BP in both arms. Typically, there may be some variance, and the one with the higher BP reading is what you are going to use for subsequent measurements. Okay, it's going to give you a better view of what the patient's BP is and the risk that thereof. So typically at the first time you do the 2, and where the BPs are high is where you are going to do first. And you need to let the client know, so that subsequent ones, it may prompt the clinicians or the staff that, this is where we have been asked to be issued because it was higher the first time. The patient should be comfortably seated. The arm should be exposed and supported at the level of the heart. The level of the heart is very important. So you come to realize that even if for one reason or the other, you cannot use the arm, calves, and you're using the wrist calves, then you need to actually bring it to the level of the heart, because if it's taken higher or lower, the level of the heart, the measurements may not be accurate. Feet flat on the floor, and the legs should not be crossed. Feet should be flat on the floor, the back supported, the legs should not be crossed. Ensure that the patient has not smoked or ingested any caffeine-containing foods or drinks during the past 30 minutes before you check these BPs, and make sure that they've emptied their bladder, or they are not having any urge to go and urinate, because otherwise they are it's going to push their BPs high. The appropriate cuff size should be selected. Typically, we say that the large ones, which is 15 cm, is preferred for patients with mid-arm circumference, which is more than upper arm circumference, which is more than 33 cm. For those below 33 cm, you could use 12 cm. But typically, we say that the bladder, within the calf, should encircle at least 80% of the arm during the BP measurement. So if you are going to use the bladder, the calf bladder, you are going to look at the length of it being about 80% of the patient's arm circumference, and that is the appropriate calf that you need to use. There are times that we realize that people are checking BPs and the calf is small, and they bring it down to the forearm, and they'll get good values, write it nicely for you. If you are not careful, you act on these things. So we need to know that it is supposed to be at the right places, at the arm, at the level of the heart. If you don't have, and for one reason or the other, you cannot use the arm one, you can use the wrist, but should be at the level of the hand. Must make sure that the cuff size is appropriate. And appropriate, we are looking at 80%. I mean, the length being at least 80% of the mid-arm circumference. In patients with suspected orthostatic hypotension, especially in the elderly and diabetes, it's good that during the readings, you do at least standing BPs as well. Okay, after 1 to 3 minutes of standing, you can do a check to know what the values are. If it's too low, then it will help you in making some decisions. In patients with atrial fibrillation, as I've said, irregular pulse, the manual auscultatory method with an aneroid sphere is preferred. But if you don't have, then we could do repeated ones with automated or semi-automated ones. And let me say it again. These days, we realize that at most of the clinics, that our old manual ones have been thrown away. It still has a place, especially in patients who will have irregular pulses. So you need to have them so that you can use them. Out of clinic blood pressure monitoring, extremely important. That we said for white coat hypertension and other things, you want to probably confirm this with a home BP monitoring. And for this one, a self blood pressure monitoring that involves the use of validated. The word is validated. When you go to stridebp.com, www.stridebp.org, I mean, you can check whether the machine that they are actually using is validated and it has passed the accuracy test. So you can check your BP machine, you can let your clients check it. So it must be validated. And 2, intermittently, it's good to also get the biomedical engineers to validate it with other manual ones or other monitors that have been validated, just to make sure that the one that they are using at home is a good one and is giving you accurate results. 2 readings should be taken in the morning and the evening before medications where applicable. And of course, the average of these BPs are what you have to use in taking your decision. So you tell your client that they should have a book, draw their lines, have the morning BPs, evening BPs before they take their medications. They take 2 readings. In the evening, they take their readings. They can find the average and put it there. It helps a lot in making decisions. For the ambulatory BP monitoring, it involves the use of a device that records and provides average BP measurement over a period, usually 24. There are some of them that can go up to 48, but usually 24 hours. And this one is set up to take your BPs every 15 to 30 minutes. And of course, at the end, it gives you an average. It's able to give you your average night BPs and the daytime BPs. And as we said, in the evenings, during the sleep, the BPs are supposed to be below 120/70. So it helps you to know whether there is nocturnal hypertension. And during the day, which is high, we are looking at 135/85. And if you are looking at the average of it over the period 24 hours, then we are looking at 130/80. It's good to have these figures so that when you have them, it can help you to take your decisions. What are the goals and principles when it comes to treatment? I would say that the primary goal of hypertension treatment is to reduce the cardiovascular and renal morbidity and mortalities by lowering the blood pressure, usually to target. And we'll look at the target that we are expecting per the current guidelines. To control, the first one is to control and maintain BP at the target levels. So anybody that comes to you, you've diagnosed, confirmed that they have hypertension, you need to control and maintain a target. As you realize, only 6% of those who are known to have hypertension in the country, for the work that have been done, it was a systematic and meta-analysis, systematic review and meta-analysis, actually having controlled BP. It means that we are not doing well as clinicians, so we need to do more. The word is that you need to get them to control, knowing your targets. 2 is to promote a healthy lifestyle. Of course, you are doing all this to reduce your cardiovascular risk. BP or hypertension is not a standalone. They are contributing to other things. The overall cardiovascular risk should be worked on. And you need to also help you to control your BP. So if you are promoting lifestyle, healthy lifestyle, then you are going to achieve this. And these days, one of the things that we are pushing per guidelines is to assess and control the risk factors, and also look for the hypertension-mediated organ damages, because you need to look at them. It helps you to know, what is going on, the complications that they are, so that you can manage them even better. Only a few people actually, when they see clients with hypertension, actually calculate or work out their cardiovascular risk, but it helps a lot. And even for those with elevated hypertension, as we said, more than 120, you need to calculate their cardiovascular risk. And if the cardiovascular risk is high, you may need to consider, discuss, and start medication with the lifestyle. Currently, the target is that we are doing the systolic between 120 to 129. 120 to 129. Level of evidence is A. For most guidelines, this is where the target is. And if you realize that if you are going to do this, then we are going to reduce improve the outcomes and also reduce Okay, sorry for the technical. The little technical issues. For the diastolics, we are looking at target control of 70 to 79. And it been realized that if you're able to get to these targets, the outcomes in terms of protecting the cardiovascular risk and events much, much, much better. So we need to be aiming at this. And as I said, it should be patient-centered. We don't have time to go into patient-centeredness, but it should be patient-centered, and make sure that if the client cannot tolerate, you don't push it there to give them problems. For lifestyle, I will rush through, but it's extremely important, especially as a primary physician, for a client who is known to have hypertension or even some cardiovascular risk factors. Your lifestyle modification should be paramount. And you should, in no case should you have a client who is known to have hypertension that goes out of your clinic without scheduling or working on them improving their lifestyle. Yes, you may start medication, but the lifestyle modification is very important. We'll go through a few of them. Reducing salt intake by avoiding adding salt to foods. A lot of time when you ask them to, the 5 grams per day is difficult, but it's good to let them know that you don't have to take, salty stuff and adding additional salt to your food. Alternatively, potassium-rich and low sodium salt may be useful and actually is recommended. The regular intake of fruits and vegetables, fish, unsaturated fatty acids like olive oil, consuming low-fat dairy products, and reducing intake of red meat. This is the healthy diet. We cannot go deep into it, but healthy diet is extremely important. Always remember your salt. Always remember your fruit and vegetables. Always remember your unsaturated fatty acids, reducing saturated. Always make sure that whole grains are preferred and all that. Very important. Weight reduction is also extremely important. You realize that it's part of the risk, and it's also a major risk factor for cardiovascular diseases. And you will need to let your clients know and actually help them to make sure that they are keeping their weight within normal range. These days, It's even better to use your waist circumference. Abdominal girth. For men, we are looking at less than 94 cm. For women, we are looking at less than 80. So if you are there, you can check yourself whether you qualify. I'm on borderline, so don't ask me. The last time I checked, I was 94. So I'm still managing a borderline abdominal. But it's a major risk and a lot of work. One work that I actually did myself, realized that it's actually a better even predictor of cardiovascular disease for a lot of work that is coming up. So it's one thing that we will need to it's not come back.
Where's your email? That's okay. That's connected.
Sorry for the technical itches, but I hope that we can flow from here. So we're looking at the lifestyle modifications. And we talked about the waist circumference, and I humbly ask that you check to see whether you are yourself within range of your clients. It's very easy to do. Regular exercises. So we are talking about 30 minutes of moderate intensity physical activity, 5 times a week, or we say intensity physical activity. I always will advise that don't push your clients to do vigorous, because for vigorous, it's good that we're getting a lot of people who are doing vigorous, they've fallen, they've had cardiac arrest and all that. If you think you want to do vigorous, want to go and play football like Ronaldo and other things, please get yourself assessed to make you are fit to do a vigorous. Otherwise, do a moderate. I mean, 150 moderate intensity. Can do your walking, brisk walking, your jogging, your cycling. Those of you who know how to swim, you can do. If you want to skip, skipping, I normally will not push for it, and that's about 5 minutes. But in exercise, you need to do at least 10-minute sections. So they normally will not hit their 10-minute sections. They will sit, take a drink, skip another 300. So skipping sometimes, people are not able to meet. But if you can skip continuously for at least 10 minutes in sections and make your 30 minutes, it's good. Reduce or avoid alcohol. Per the 2023 WHO guidelines, they actually recommend that we avoid alcohol completely. I mean, these are things that in my hometown, if you tell them, they may not come to clinic. Start by telling them reduce it, then you aim at actually stopping. So that you need to know how to go about it, but you need to let them know that per the recommendations, they may need to totally go off. Smoking is a no-no. These days, two things that we want to stress on is restorative sleep. It's been realized from a lot of work that have been done and guidelines that it's becoming a major risk factor for hypertension, vascular diseases. For restorative sleep, you are looking at least doing 7 to 9 hours of sleep. And your third stage of non-REM, you may need to do, at least 1.5 hours, and your REM about same 1.5. So if you're able to do your 7 to 9, then you're able to meet the recommendation. And that's when a lot of restoration takes place. And it's recommended that we do that. So we need to let our client know that we need to do 7. Last time I was making a presentation, somebody asked me a question, doctor, have you been doing that? I'm trying, but that's the recommendation we need to do if we need to reduce the risk. Stress management, now the system is stressful. There are a lot of recommendations how to reduce the stress. Techniques, exercise, your dieting, healthy dieting, and all that. If you have challenges, you can see your clinical psychologist to help you in terms of management, but it's a major risk factor that we need to discuss with our clients. We need to assess and manage the hypertension-mediated organ that you see a client who's not to have hypertension. Please assess them with a lot of them. So you are looking at, the kidneys to see how, they are doing. You are looking at behind the eye. You are looking at the heart. You are looking to see whether there are some damages already, so that you can, know how to see clients. We just give them medications. We don't assess some of these things. So you don't even know how far your clients, have gone. So you can manage it as well. The other one is to assess and manage other cardiovascular risk factors. It's been found that when you have more than, other cardiovascular risk factors, it's become cumulative in terms of their cardiovascular risk. So if somebody is known to have diabetes in addition to their hypertension, then their risk increases. If they have dyslipidemia, it increases. So you need to assess all the other cardiovascular risk factors, diabetes, dyslipidemia, obesity, all the others, and make sure that you are. I want to stress on here. I've stressed on over and over, and I want to stress again that whenever you have a client who's known to have hypertension or even elevated blood pressures, please, let's work on their cardiovascular risk. The WHO ISH risk estimator is what has been validated for our environment. Very easy to use. I wanted to bring that, but you can Google it. It's a risk estimator. You can have the one for the laboratory-based one and the non-laboratory. Of our colleagues are in places where they may not have access to certain labs. So let's say if you cannot do the lipid profile and know your total cholesterol, do the non-lab-based, you can use the non-lab-based risk estimator, and that is going to help you to calculate the client's risk. If they have their total cholesterol, you can use the lab-based one to calculate their cardiovascular risk. And especially if the cardiovascular risk is moderate or high, then you need to manage them. For those who have elevated blood pressures, if the cardiovascular risk is high, you will need probably to reduce the blood pressures. Consider, you need to discuss with them. It's patient-centered. Discuss with them the risk, and especially those that are more than 130, try to control them and bring them to normal. Diagnostic investigations that normally we would do: full blood count analysis, looking for your proteins, the blood sugar, looking for some risk factors. Of course, your kidney function test, looking to see whether there's damage to the kidneys, your lipids as a risk factor, serum, uric acid, chest x-ray, probably may see left trophy and large heart. you can do your ECG. That could also help you. Fundoscopy to look at the back of the eye. There are other labs that are done to actually help identify hypertension-mediated organ damages or clinical suspicion of secondary hypertension. So we are not saying that for every client that you see, you are going to do all of them. Of course, it also depends on the level that, you are. If, we send a client to Sheila and it's a resistant hypertension, he may go further to do other tests to see what may be causing that, and may do a lot of other ones. But the basic one that at least at the clinic, we need to know when we are managing them initially is this ones. For the initial treatment, just trying to make it a little simple. So whenever you've confirmed, so normally when you have the client's BP's checked, you think they are high, you confirm. When you confirm that it is hypertension, especially for those between 140, 159, and diastolic between 90, 99, there's a room to start lifestyle modification and see whether, it will get improved. Especially if they don't have other risk factors. But when they already have end organ issues, the risk factors, more risk factors, is high. This is not the one time to be playing around lifestyle. You may need to start treatment. And for those that are between 140 to 159, and that's between 90 and 99, the thiazide diuretics and the calcium channel blockers are first line that you could use. After 2 to 4 weeks treatment, if the response is not adequate, then you can add a second. Then you can add a second medication. Of course, if you started with the thiazide diuretic or thiazide diuretic, then you add the calcium channel. If you did the other way, then you add the other one. So typically, if you think that there's no end organ, the risk is low and all that, you can start with a lifestyle. Or depending on the other risk factors and the risk and other things, you can start lifestyle and start your medications. But even if you are doing some lifestyle, you've seen a client, the BPs are 141, 142, you want to do lifestyle, you don't want to start. After 3 months, you are still around there. You can't continue that. You need to start managing and make sure that you are managing to target. Typically, if it's more than 160 or the diastole more than 100, then you want to do at least 2 medication, the drug therapy. We always prefer that if you can do a single combination therapy is best because compliance is much, much, much better. Typically, of course, you blockers and your thiazide or thiazide diuretics. But of course, if they have less hypertension and other things and kidney issues, you may need to start ARBs first. After, sometime if it's not getting controlled, then of course, you can add your ARBs or your ACE inhibitors. So typically you add third medication if response is not adequate after 2. ACE, ARB plus CCBs plus the thiazide diuretics or the remains the 3 combinations that are best, except in other situations where for specific conditions you want to use some other medications too. So let's say if you have atrial fibrillation, of course, your beta blockers will come inside. So for those specific ones, then the first lines may change. But we always recommend that if you have those cases, you have to be managing with a specialist so that it's managed well. And that's why we didn't bring those lines in here. If BPs remain uncontrolled or there are complications, kindly refer to a specialist or a secondary facility to support you with the management. Criteria for referring to a specialist or a higher level. Of course, you may be a specialist, so you are managing yourself, but at the lower primary care facilities, when you have a pregnant woman with hypertension, please, if you try playing with it, it might get you into trouble. It's good to send to a place where there's an obstetrician as well to help manage. Patients with abnormal results on urine dipstick. So you think that a lot of, there's anemia, the creatinine is high, they have other things, please try to refer to the specialist or a higher level. For children and adolescents, you can have a lot of, it can be secondary hypertension, a lot of things may come in there. It's good to refer and manage with a pediatrician as well. Patient with suspected secondary cause, you will need to refer to a higher level. Patient with heart failure, stroke, atrial fibrillation, renal insufficiency, all this one you may need to. For patients who are 80 years and above, I mean, hypertension for the first time, there are a lot of things. You may give their first medication and they may go hypotensive, or things may happen, and I mean, there are issues. So it's good to refer those clients as well. Those less than 40, if you're not too sure of the diagnosis, you may need to refer. You always will need to, if you don't have the capacity to do certain investigations, then you may also need to refer for them to at least do and co-manage with them. Some complications, I'm sure we know all this already, so I'm not going to spend time on it, but there are a lot of complications when it comes to hypertension when they are not managed well. And these are the list of them. Prevention, prevention, prevention. I cannot live here without talking about prevention, especially for us at the primary care level. We need to involve our clients in making sure that it's prevented even before they get to some stages. So primary hypertension prevention is hinged mainly on avoiding and controlling multiple risk factors. And we've talked about them. So anytime that you have a client, you know that they have elevated BPs, they are not yet diagnosed with hypertension, start your lifestyle modification, lifestyle modification, lifestyle modification. And we've gone through them already, but you need really to do that. Refer to a non-pharmacological management of hypertension for lifestyle modification to prevent primary hypertension. I've said already, especially for those that have elevated BPs. There are a few things that I want to talk about, few relevant recommendations that I want to highlight here. Tell women who take angiotensin converters and the ACE inhibitors and the ARBs that there's an increased risk of congenital abnormalities. This you must let them know. So if you have a client who is preparing to get pregnant, I mean, you need to let them know that there are some congenital abnormalities and they may need to stop it if they are trying to get pregnant, and you may need to change to other medications. For diet and exercise patterns, you need to address them for everybody that you are trying to manage to reduce their blood pressures. So always make sure that for diet, exercise, and the other risk factors, you are actually working on it. Offer appropriate guidance and written or audiovisual materials to help them with some of these things. In terms of promoting lifestyle changes, you need to be patient-centered as well. So you need to discuss with them. It's not like telling them go and do this, but you need to really discuss with them. Always discuss reduction in sodium intake and substitute with potassium enriched sodium salts. Actually also helps a lot. Some few key messages I want to bring about are chronic medication, a chronic medical condition, and the leading cause of cardiovascular deaths in the world. Hypertension is largely asymptomatic. I should have written it in red. So every encounter with adult patients is an opportunity to screen. Diagnosis of hypertension should be confirmed. A lot of times people come in, we check BPs 145, it could be white coat, then we push in the medications. We need to confirm. You could do repeated clinic, measurements over visits, about 2 visits to confirm, or you can do the home BP measurements on the ambulatory. Just confirm, and if it's confirmed, you can start your treatment. Hypertension cannot be cured. We need to let our clients know that, and it requires lifelong pharmacological and non-pharmacological treatment. Adequate treatment prevents cardiovascular diseases and cardiovascular disease-related deaths. Strict compliance with medications and regular follow-up are necessary to prevent these complications. So you need to discuss with your clients on compliance, and always make sure that on your review, you are making sure that they are up to target. And as I've said, single pill combination therapy is always preferred. It helps with compliance. Thank you very much. I think I'm done with my section. Thank you for listening to me.
Thank you so much, Dr. George Nketia, for this insightful presentation, letting us understand the basics. Over 90% of patients with hypertension we see at our clinic actually from a primary cause. and letting us know that every adult that comes to our clinic, whether for something else, you're seeing the patient for malaria, for UTI, for anything, you should make it a point to screen these patients and have their blood pressure checked. And thank you, Dr. Nketia, for also letting us know that now there's nothing like your BPs are normal. The current guidelines is non-elevated. So don't go reassuring people, telling people that they are normal. And as hypertension is purely asymptomatic, people will be thinking they are fine. So this CPD is proudly sponsored by Ethica. They will be speaking to us shortly, but we are happy to collaborate with them to give this opportunity and have this CPD free for primary caregivers, family physicians, and doctors who will log on. So thank you so much for collaborating with the Society of Family Physicians of Ghana. So without wasting my time, we will move on to our next speaker. She is a cardiologist with the University of Ghana Medical Center with over 17 years of experience in patient-centered medical care. She's known for her dedication to excellence and calmness. And I always, when I see her, there's some calm nature about her, but very astute in making sure that cardiovascular diseases are well managed in this country. She's a fellow of West Africa College of Physicians and also holds a postgraduate diploma with preventative cardiology from the University of South Wales. I'm talking about Dr. Sheila Atukefiu, and she has also contributed immensely to medical education. Usually she helps us with CPDs. She's done a lot in the past and is passionate about how primary caregivers are able to, what we can do in our part to prevent cardiovascular disease. So this afternoon, please help me introduce Dr. Sheila Atukefiu as she takes us through resistant hypertension and long-term risk reduction as we see these patients.
Thank you very much, Baba. And thank you to the Society of Family Physicians of Ghana for this kind invitation. And thank you, Dr. Nketia, for this very extensive overview of hypertension. It was very detailed, and I'm sure we all learned a lot. You've made my work very, very easy. This afternoon, we're going to talk about a very important topic, resistant hypertension and long-term risk reduction. This will be our outline of the presentation. Why is this topic so important? Dr. Nketia has already spoken about the importance of hypertension, so I'll not go into that. But studies have shown that patients with resistant hypertension are unfortunately at a higher risk of poor outcomes compared with patients without resistant hypertension. And in one large study of more than 400,000 patients, they found that compared with patients without resistant hypertension, those who had resistant hypertension had about a 32% increased risk of developing end-stage renal disease. They had a 24% increased risk of ischemic heart disease. They had a 46% increased risk of developing heart failure, about 14% of developing strokes, and a 6% increased risk of death. So that tells us that resistant hypertension is a very important phenotype of hypertension, and it's an important public health problem that we need to talk about and learn how to manage. So what is resistant hypertension? It's defined as blood pressure that remains above goal. Now, Dr. Nketia has spoken in depthly about the goals of management and the values, so I'll not go into that. So it's blood pressure that remains above goal in spite of the use of concurrent use of 3 antihypertensive agents. And these should belong to different classes, and they should have been prescribed at the maximally tolerable doses. So we need to take note of the caveats with the presentation, because before we say that somebody has resistant hypertension, we should make sure that all these 3 are present. And typically the preferred antihypertensives are calcium channel blockers, either an ACE inhibitor or angiotensin II receptor blocker, and they should also include a diuretic. Resistant hypertension can also be said to be present if you have a patient requiring 4 or more antihypertensive medications. So even if the BPs are well controlled, they are still classified as having resistant hypertension. The prevalence of true resistant hypertension. So we'll talk about true resistant, certain terms, apparent treatment resistant hypertension and all that. But it's largely unknown for obvious reasons. We'll soon understand why it's difficult to know the true prevalence. But largely, it's been said to be around 10 to 30% in general practice. But in nephrology referral clinics, it can be as high as 50%. Now, participants of a large study in the US, the National Health and Nutrition Evaluation Survey, when statistical evaluation were done, they found that about 53%, only about 53% of the participants had their BPs under control. In Africa, the data is not much, but it's been said to be around 19%. And in Ghana, A.C. Boateng et al. Found, they did a multi-center study in about 5 hospitals, and they found about 18.9% of apparent treatment-resistant hypertension. And then Prof. Safo and his colleagues also did a study in stroke survivors and found that as much as 45% of them had their BPs poorly controlled, and they actually had resistant hypertension. It's typically commoner in males, the elderly, patients of African descent, and then patients with hypertension-mediated organ damage, such as left ventricular hypertrophy and kidney disease. So we need, like I mentioned, we need to understand some terms going forward in order to properly diagnose resistant hypertension. So what is pseudo-resistance? Now, this refers to poorly controlled hypertension that appears resistant to treatment, but may actually be attributable to other factors. The commonest factors identified are improper BP measurements. We've learned about that. Medication non-adherence, unfortunately, suboptimal antihypertensive therapy, white coat hypertension, and then poor adherence to lifestyle and dietary approaches to lower BP. So before you diagnose someone as having resistant hypertension, you need to be sure that you've excluded some of these factors. And apparent treatment-resistant hypertension is basically patients who meet the criteria for resistant hypertension, but unfortunately, we've not been able to verify adherence, or their treatment is inadequate, or they've not done out-of-office BP monitoring that we learned about to rule out white coat hypertension especially. And you see that most of our patients fall under this category. We've really not excluded these things, so we can't say for sure that they have true resistant hypertension. The pathophysiology of resistant hypertension is the same as hypertension, so I'll not go into detail, but a combination of environmental factors, lifestyle factors, genetic factors, and of course, the neurohormonal model that affects BP control. Now, how do we diagnose resistant hypertension? Like I mentioned in the previous slide, it's crucial to rule out pseudo-resistance, especially due to medication non-adherence, improper blood pressure measurements, and then white coat effect or white coat hypertension. Now, what is medication non-adherence? So this, we all know, it's a discrepancy between how we prescribe our medications and how the patient is actually taking it. Now, it's a big thing when it comes to resistant hypertension, because you need to be sure, first of all, that the medicine you are giving your patient is being taken. Now, it's a major cause of lack of BP control. And unfortunately, the prevalence is difficult to determine. For obvious reasons. Sometimes the information is not readily volunteered. It's difficult to track down our patients and all that, but it ranges from 3% to as much as 86%. And several studies pulled together found that after about 5 to 10 years of follow-up, less than 40% of our patients would actually persist with their prescribed antihypertensive treatment, and that's a huge proportion. It's likely to even be more in our environment, unfortunately. Now, there are what are some of the reasons for medication non-adherence? Again, we all know the cost. Sometimes the patients start out well, they'll tell you they can afford it, but then along the line, for certain reasons, they are unable to, and we are not told. Then complex dosing regimens. Dr. Nketia spoke about the combination pill being preferred because then it reduces the pill burden for our patients. Sometimes the side effects, we all know, discourages the patients from taking the medication, especially erectile dysfunction, pedal edema, and all that. And then sometimes basic lack of understanding, either from our parts or our patients, unfortunately, sometimes being in denial, just cannot accept the fact that they have to take these medications long term. And so they take the medication for a while, it runs out, and they don't see us again. Now, there are certain clues that would point to medication non-adherence, and we know those who often miss their office visits default. It's likely they are not taking the medication well. And sometimes those who cannot even tell us the name of the medication, even if the patient is not well educated, they can describe the tablets. We hear that they describe the tablets, they tell us how often they are taking it. But if they cannot tell you any of these things, then it's likely that they are not taking their medication. And then lack of physiologic evidence of therapy. So you have a patient who is on a beta blocker, an optimal dose, and they come in always tachycardic. It's likely they are not really taking the medication. At that point, you need to probe further to see whether it's really because there's a problem or they are just not taking the medication. We need to have techniques to improve drug adherence, and elsewhere, they have documented things like checking pharmacy refill records, urine diuretic screen, endurance serum and urine assays. These are not very feasible here. We don't do it often because it's expensive, and with our large patient burden, sometimes it's not possible to check everybody's refill records, but we can involve the family members. This works a lot. So they come in with someone, we explain things to them, and then when they come back, we ask them. And then the directly observed therapy is very easy when they are on admission, but at home would need help from the family members to be able to dish out the medication sometimes. That's the surest way of making sure that they are taking the medication. Now, the next cause of pseudo-resistance that I mentioned was improper BP measurement. And thankfully, we've gone through this very well. So I'll skip this part, but it's very important, several points. And if we are to take a survey of how many of us actually do this or enforce this, most of us do not. But most of the guidelines, like Dr. Nkitia said, they are emphasizing on proper BP measurement because that is key to the diagnosis. And when it comes to resistant hypertension, you are going to be using some very powerful medications, some with some side effects. And so you need to be very sure that you are getting correct BP values before you escalate treatment. So this cartoon is just showing us what not to do when we are checking BP. It looks funny, but actually sometimes we do not enforce things. So the doctor seems to be chatting with the patient. Patient looks very anxious, legs dangling. We need to watch out for these things and make sure that at least we are getting fairly good BP values. Wide coat hypertension is another cause of pseudo-resistance. Again, we've spoken about this. Their clinic BPs are high. And we learned about the out-of-office BP measurements, which are crucial in diagnosing wide coat hypertension, ambulatory BP monitoring, and the home BP monitoring. We've gone over this. And we need those, like Dr. Nkitia said, even if you do not have an ABPM, let them check the BPs, let them bring the BPs to you. If your patients are always feeling dizzy at home, likely due to hypertension, you need to check these things to be sure. About 20 to 30% of those on treatment can also have wide coat hypertension, and this is known as the wide coat effect. So that's those already on treatment who come with higher clinic readings. Unfortunately, there are some physician factors that also cause pseudo-resistance or apparent treatment-resistant hypertension. Basically, physician inertia. So sometimes we are very slow in starting medication and optimizing treatment. But when the patient comes, we need to take the drug history. Once you confirm that they are really taking it, if you need to add on, if you need to take out something to replace something, we need to be a little bit proactive in doing that, because it's been found that that is one of the causes of resistant pseudo-resistance. And inadequate doses or inappropriate drug combinations can also cause that. So this study done in 2015 is just showing us the estimated prevalence of the causes of pseudohypertension. We can see that under treatment, mostly from physician factors, was the largest cause of pseudohypertension. So we need to take note of that. So what are the causes of true resistant hypertension? Lifestyle factors have been found to play a major role. And so I'm glad that we've gone over that extensively. Obesity is a problem, it's associated with more severe hypertension, a need for an increased number of antihypertensives, and an increased likelihood of never achieving BP control. And so we need to talk to our patients, we need to ensure lifestyle modifications. Excessive dietary sodium, I'll go right on because we've spoken extensively about that, but it also leads to resistant hypertension. And then lack of exercise, heavy alcohol consumption, smoking, especially tobacco smoking, all lead to resistant hypertension. And so this is a summary of the lifestyle interventions and the expected systolic BP reduction for each of them. Now, this should tell us that no amount is too small. When it comes to lifestyle interventions, it's not an all or none thing. Any change is beneficial. And so we need to encourage our patients to start small and maintain consistency, because no matter how small the reduction is, it helps to better control the blood pressure. And then there are there's a tall list of medications that can actually cause resistant hypertension. The NSAIDs, glucocorticoids, again, I think we've gone over this, the contraceptives. And so our history taking needs to be very extensive, needs to be detailed. We need a good drug history, because sometimes they'll not volunteer things like nasal decongestants. If we don't probe, they may not tell us. They may not tell us about history of depression, for example, and hence are on antidepressants. They may not volunteer, but if we start asking direct questions, the patients will tell us. And then the other cause of true resistant hypertension, or major cause, is secondary causes of hypertension or secondary hypertension. Again, we went over this extensively. And the reason we need to remember them is in order to tailor, especially our investigations. Some of the investigations are very extensive. And so we need, expensive. We need a guide so that at least we can narrow things down a bit for our patients. And then also it will help us to make the appropriate referrals to the specialist responsible. Again, this is showing us the prevalence of secondary hypertension in terms of the causing resistant hypertension. You can see that renal causes are by far, in terms of the secondary cause, the commonest cause of resistant hypertension. So I'll go over this. Dr. Nketia went over this, but it was just to emphasize the screening investigations. We can read all later so that at least you know what to request for who. So how do we evaluate and manage our patients? So the evaluation should be directed toward, first of all, confirming true treatment resistance. And I keep emphasizing this. And then identification of the causes contributing to treatment resistance, especially the secondary causes. History, physical examination, and laboratory investigations come to play. Our history needs to be very extensive. We need to know about how long they've had hypertension to start with, all their previous medications, including the side effects they've had, because that would determine what you start with, what you add on. If they've had issues with previous medications, they are not likely to take them if you add them. So we need to take a full history, examine them well, like my colleague mentioned, and then request the appropriate investigations, which is basically tailored towards identifying secondary causes. Now, non-pharmacological treatment of resistant hypertension, lifestyle modification, very simple. We keep emphasizing that because it's true. That simplifies the management. reduces the number of medications you are put on, and then reduces long-term risk. When it comes to the pharmacological management, we'll go into a bit of detail soon, but this is sort of a bit of a summary slide. Before you diagnose the patient as having resistant hypertension, they should be on a standard triple regimen. It should include a diuretic, especially thiazide diuretics, an ACE inhibitor, and ARB, and then a long-acting calcium channel blocker. And thiazide-like diuretics are now preferred to the conventional thiazides we know, like bendroflumethiazide and hydrochlorothiazide. So chlorthalidone, various studies have shown great benefits in resistant hypertension. It's not very common here, but we have indapamide, which is also very good. And so those two. And then aldosterone antagonists are also more useful. Initially, atenolol was widely used, but it's been found that it doesn't have much cardiovascular benefits or mortality benefits. And so the newer beta blockers, i.e. carvedilol, nebivolol, labetalol, well, labetalol has been around for a long time, but it has good vasodilatory properties, and so those are preferred. And then we have the alpha blockers, and then the direct vasodilating agents are also used. And we need to bear in mind that beta blockers should be among first line, depending on the comorbidities the patient has. So if your patient has heart failure or ischemic heart disease, then blockers should come way higher than normal. And so this is summary of the recommendations. Is basically what I've said. Before you proceed to step 2, you need to be sure that you have optimized your 3-drug regimen. And so it's not enough to know that these patients are on, for example, a calcium channel blocker, an ARB, and a diuretic. What are the doses? Sometimes the problem is they are not able to tell you, but if you know, then you'll be able to optimize them to fit the patient. Now, we need to also remember that these are algorithms or guidelines. We always need to tailor them to fit the patient, our patient seated in front of us. And so we need to put everything together, their comorbidities, their age, in order to choose the medications well. So after optimizing your medication, is the patient, have you maximized lifestyle intervention? What are they doing? Are they trying to lose some weight? Are they exercising? Have you excluded other causes of pseudo-resistant, like white coat hypertension, medication not adherent? If you have done all these and BP is still not a target, then if your patient is not on the recommended diuretic, i.e. the thiazide-like diuretics, you may want to substitute and put the patient on chlorthalidone or indapamide. And then if your BP is still not a target, you consider spironolactone, and you move on to a beta blocker. Like I mentioned, depending on the comorbidities your patient has, you may want to start your beta blocker right from the start. And then you consider hydralazine, there's minoxidil as well down there. So it all depends on the BP, the side effects. You need to remember the side effects and know how to combine these medications for the patient. So a quick note on the diuretics. I wanted to re-emphasize them that they are now preferred, but we still have patients who have who are on hydrochlorothiazide because it's readily available. And we need to know the common doses. Typically 12.5 to 25 milligrams a day are effective, but you can increase to 50 milligrams, that's hydrochlorothiazide. Bearing in mind the side effects of electrolyte imbalance, and so we need to be checking their renal function. However, in patients with an eGFR below 30, the thiazide or thiazide-like diuretics do not work well. And so at that point, the loop diuretics, good old furosemide, works. These are short acting, and so they must be dosed at least twice daily. We need to remember that There are longer acting loop diuretics like torsemide, which can be given once a day. It tends to be a little bit more expensive, but it's available. And once a day dosing of furosemide for hypertension management is a very common dosing mistake we all make. We need to remember that it doesn't work well that way, and then we give them in divided doses. I've spoken about the calcium channel blockers. Dr. Nketia spoke about combination therapy is now, it's been the go-to, standard for a long time. Various trials have come with various outcomes saying that calcium channel blockers and ARB combination better than the diuretic ARB combination. There are several, but what we do know is that when combined together, they work very well. Cost may be a problem, and so we need to talk to our patients before we put them on these medications. The beta blockers, I spoke about them, the fact that the newer ones are now recommended. We still have some of our patients on atenolol, especially our elderly patients. They've been on atenolol for years, and they are usually very reluctant when you suggest that you want to, substitute them. So our patients need to agree, but those that we can readily convince, the newer beta blockers are currently guideline recommended. And then I've spoken about the direct vasodilators and then the peripheral alpha blockers. Very useful, especially those with BPH, benign prostatic hyperplasia, as an add-on. And then I just wanted to re-emphasize spironolactone. Across board, several trials, including the large Anglo-Scandinavian cardiac outcomes trial. They've repeatedly proven that spironolactone added as a fourth drug is very useful in managing resistant hypertension. And we can go, when it comes to hypertension, as high as 50 milligrams, but we need to look out for raised serum potassium and gynecomastia. In case the patient develops gynecomastia, we can switch to eplerenone as an option. Recently, there are some novel agents for the treatment of resistant hypertension. One is aprocitentan. It's a potent endothelin receptor antagonist. We know the endothelin pathway is the vasoconstriction pathway. And so this helps in has been found to lower the BP as a fourth drug. And then good old or good new SGLT2 inhibitors, the wonder drugs now, it's been found that they also cause some BP reduction, about 5 millimeters of mercury, due to their natriuretic effect. And so these agents are currently licensed for use in resistant hypertension. And then there are device-based therapies. They've been mainly experimental when it comes to renal denervation, which is just catheter ablation of the renal sympathetic nerves. Initially, there were 2 trials, the Simplicity 1 and 2, which showed some benefits. And then there was a Simplicity 3 trial, which did not show any benefits. So trials are still ongoing, but these are also available or potentially available for the treatment of resistant hypertension. So I put together a step-by-step guide, again, just to quickly go over the evaluation and management. Like I said, quickly exclude factors that can cause apparent resistance. So make sure the office BP is being well checked, exclude white coat effect, make sure your patient is taking their medication. A clue to know that this may be apparent treatment resistance is that they do not tend to have target organ damage. And so you have a patient who always has in office very elevated BPs, and you do screening, they do not have LVH, they do not have renal impairments, they are fine. That's a clue that maybe they have white coat hypertension. So we need to exclude these factors. And then we identify and reverse factors that may be contributing to true resistant hypertension. So if the patient is on any medications that may worsen high blood pressure, we need to take them off. We need to identify any lifestyle factors that may be contributing. And so we encourage them to stop alcohol, reduce their salt intake, exercise more, and lose some weight. And And then we need to work them up for secondary causes of hypertension. I separated kidney disease because it's one of the major causes of resistant hypertension in our environment. And then the pharmacologic principles we've spoken about. Let's remember to look out for those who are not on adequate treatment and add on where we need to. Let's make sure the patient are on diuretics because it's the cornerstone of therapy in resistant hypertension, and look out for their age, their comorbidities, because that is what will determine the best combination of agents that you would use to achieve the BP goal. And if the therapy has progressed to needing a fourth agent, we need to consider referring to a specialist. Dr. Nketia spoke about that. So either a cardiologist or, depending on, commonly they need endocrinologist or nephrologist. So it depends on what we find. So a quick note on long-term risk reduction. We have spoken about this, both of us. It requires a comprehensive approach, typically between lifestyle, intense lifestyle modification, and then optimizing your pharmacological treatment. And the risk reduction should focus on global cardiovascular protection, so not just the BP numbers, and so we need to holistically monitor our patients, give them the advice they need. I like that Dr. Nketia spoke about sleep and then also stress management, because sometimes the high BPs you are experiencing or our patients are experiencing might be some stressful occurrence. And if we don't talk to them and offer them help, we may not know. In 2010, the World Health Organization and the Center for Disease Control came up with this concept of life's essential 8, which set to state key measures for improving and maintaining cardiovascular health. And it involves not smoking, being physically active, having a normal blood pressure level, having a normal total cholesterol, normal weight, eating a healthy diet, and getting good. Intense lifestyle modification is key in the management of both hypertension and resistant hypertension. So in summary, resistant hypertension is a high, it leads to an increased all-cause mortality and cardiovascular disease outcomes. In our evaluation, we need to remember to confirm treatment resistance. We need to exclude pseudo-resistance, identify and reverse any harmful lifestyle factors, screen for secondary causes, and then initiate the appropriate pharmacological treatment. And we need to remember that the individual patient characteristics will determine the best combination of agents we need to achieve our BP goal. Lifestyle changes, again, key to long-term risk reduction. And early referral for specialist input is crucial. Thank you.
Thank you so much, Dr. Tukwefi, for that insightful presentation. In fact, there are lots of comments in the chat box speaking about the two great presentations we have had this afternoon. Some people are asking for slides. We'll let you know how you can get access to the presentation slides. But thank you very much for also letting us know that we have pseudo resistance and true resistance when it comes to resistant hypertension. And hypertension is something that I'm also quite passionate about, because they form majority of the patients we see at our OPD. And I would like to bring to the attention of our audience that 19th May is World Hypertension Day, and the Society of Family Physicians, the Cardiology Society of Ghana, we are all bringing and making creating awareness on this hypertension menace. So please look out for what is happening, and then let's have a good session in May to look at how we can help with bringing hypertension down. So next we'll have a short presentation by will be given by Obi Joshua Payne. He's a pharmacist trained in UST. He's practicing pharmacy for a couple of years and also involved in both community and hospital-based pharmacy. Please give a let's give a hand for him as he gives us a short presentation.
Yeah. Good afternoon, everyone. First of all, I'd like to thank SoftPorg for this opportunity and for the opportunity to engage family physicians and also general practitioners. Thank you once again. My name is Sobobi Joshua Payne, and this afternoon I'll be engaging you shortly on the theme, a call to action for hypertensive patient care. My earlier speakers have done justice to this topic. Dr. Nketia has spoken extensively on how to identify it, how to adequately manage it. And Dr. Atukwefio has spoken extensively on how to manage resistant hypertension. But today I'm here to bring our mind to sensitize us on how to adequately assess patients and also prevent end organ damage. Once that goal is achieved, I'm all right for today. You know, at the start that have been presented, we realize that hypertension, being a silent killer, has been with us for ages. Every year, there are a lot of lectures on hypertension, on how we can better those statistics. It is our hope that with the intentionality of the primary health care, my focus today will be on hypertension-mediated organ damage. And one area, chronic kidney disease. So hypertension-mediated organ damage causing chronic kidney disease. So based on statistics that are presented, 1 in 5 hypertensive patients are at risk of chronic kidney disease. 1 in 3 diabetic patients are at risk of chronic kidney disease. In Ghana, we have about 13.3% of the population, which estimates to about 4 million people living with chronic kidney disease. So the main catch is, if you are able to adequately manage blood pressure, our high blood pressure, then we may reduce this statistic as well. So your hypertensive diabetic patient is at risk of chronic kidney disease. What can we as clinicians do differently? The control rate for hypertension is generally low. Dr. Nketia mentioned around 6%, but usually it hovers around 0.6 to 12.7%. So what are some of the unmet needs that we need to resolve? So one, patient not achieving BP goal, and there are various reasons. 1, due to MATE, 2, due to cost, and 3, due to other reasons as well. Also, there is increasing incidence of kidney impairment. Hypertension is the second leading cause of end-stage renal disease, and therefore we need to adequately assess our patients when they come to the clinic. We need to adequately assess them and the risks they present so that we're able to give them adequate pharmacotherapy to prevent this escalation. So what can we do differently to assess these unmet needs? This is why I want us to focus on. Per the TCR assessment, we need to go beyond the numbers. Decisions on management should not be based on BP alone, but we need to do an extensive cardiovascular risk assessment. Up to 71% of newly diagnosed hypertensive subjects present with hypertension-mediated organ damage. So patients with diabetes, chronic kidney disease, hypertension-mediated organ damage, and complications fall in high-risk category. This stratification helps us to prioritize and also give adequate medication therapy. The updated guidelines reinforces the need for management decisions to be based on patient risk factors and the right phase dose combination. ARB phase dose combination recommendation at initiation, especially for this high-risk patients. So let's take a typical patient. Anne is a typical patient who can walk into any of our facilities. She's hypertensive diabetic, a 50-year-old lady. She presents to the OPD for a medical checkup following a 3-month appointment with complaints of persistent headaches. So she has a history of type 2 diabetes and hypertension, office BP, LDL, and these parameters presented. She's on metformin, vildagliptin, 1050, amlodipine 5 milligram daily, and atorvastatin 20 milligram daily. So based on this presenting parameters, what will we consider for a patient like Anne? One, the degree of BP lowering. This has been spoken about by my earlier is diabetic, she has dyslipidemia, she's also hypertensive. So basically, she has a high CV risk. We need to screen for microalbuminuria. So BP lowering treatment should consist of a simultaneous combination of lifestyle intervention and pharmacological therapy. So with this, based on the guideline recommendation, ARBs are preferred options for hypertensive diabetic patients to achieve the 3 management goals, which is the rapid BP drop, renal protection, and cardio protection. So with this, I present Aprovel. Aprovel is irbesartan. Irbesartan is an ARB. So with irbesartan, is proven to achieve up to 31.7 millimeter mercury drop in systolic BP and up to 24.5 millimeter mercury drop in diastolic BP within 7 weeks. So irbesartan will provide 70% risk reduction in progression from microalbuminuria to overt proteinuria, and also effective amlodipine in regressing left ventricular hypertrophy. So beyond its BP lowering potential, irbesartan offers early stage kidney protection among ARBs. So this is a typical kidney continuum. So for kidney impairment continuum, so usually the major culprits, which are hypertension and diabetes. So patient presenting with these risk factors, it will deteriorate into endothelial dysfunction, microalbuminuria, microproteinuria, then eventually you have chronic kidney disease. So what we are saying today is that when we are able to identify these risk factors early, we're able to catch them early and manage them adequately, our patient would not progress to chronic kidney disease. So when patients who are hypertensive or diabetic, or even both present to the clinic, we need to make sure that we screen for microalbuminuria. So all hypertensive diabetic patients are at risk of renal disease. Management should include BP reduction and prevention or reduction in the progression to chronic kidney disease. So this is the IMA2 trial. So in the IMA2 trial, I have about 590 hypertensive diabetic patients who are subjected to the irbesartan 150 and 300 milligram. So they were followed up for 2 years to see the effect of irbesartan in preventing progression to overt nephropathy. So this patient already, if you look at the continuum, they already had microalbuminuria, and they wanted to see how it prevents progression to overt nephropathy. So at the end of the trial, it was realized that the irbesartan 150 prevent progression to overt nephropathy by 39%, whereas the Aprovel, which is irbesartan 300, prevent progression to overt nephropathy by 70%. So this goes to show that when you have a patient who is hypertensive or hypertensive diabetic, one of the best options for your patient is Aprovel. Aprovel is irbesartan, and based on this hypertension guideline, it reinforces the need for fixed dose combination. So we have irbesartan and amlodipine together. It comes as Aprovax. We have 155, 150/10, then 305 and 305. So once you are giving the Aprovel or Aprovax, you are assured of a rapid BP drop, protection, and cardio protection as well. So Aprovax is the essential choice for hypertensive diabetic patients, combining BP lowering efficacy and target organ protection. So why irbesartan and not any other ARB? Irbesartan is well differentiated from all ARBs, and these are some of its pharmacokinetic properties. It has a bioavailability of about 70%, a half-life of about 11 to 15 hours. So you have about 30 hours coverage for your patient, which is more than 24 hours. Hence, it's taken once daily, and it's not affected, its bioavailability is not affected by the concomitant intake of food as well. So this is irbesartan. It comes with other combinations as well. We have, for initiation, we have with hydrochlorothiazide, it comes as co-Aprovel. So irbesartan hydrochlorothiazide comes as co-Aprovel. We have the 150 12.5 and the 300 12.5 milligram. With the amlodipine combination comes as Aprovax 155, 150/10, 305, and 310, respectively. So with this, I bring my presentation to an end. Thank you.
Thank you so much, Ethica, for helping to keep our patients safe and to also help to control their blood pressure. Thank you so much for that presentation. We have taken notes of your medication. So with this regard, we move quickly to the Q&A session. Like I mentioned earlier, there are lots of comments. I would like to read some. Says very insightful presentation. Please will the recording be sent to us? You'll get a link to the recordings. So look out for where you saw the flyer to register for this CPD and you'll be able to find it. A lot of people are saying insightful presentation, great presentation. Thank you, Doc, for the great presentation. Thank you to both presenters. There's a recording that's going to be available on Softbox YouTube channel. So you can also look out for that and look out for it. So one of the questions is irbesartan readily available in Ghana? So before you answer that with the cost of the medication. So keep that in mind. I'll come back to you, then you continue. Then someone wants to know if it's on NHI. So these 3 questions for you to answer. But we will go to facilitators. So he says, when a person, Dr. Nketia, this to you, when a person is without arms, how else can we check their blood pressure? And what cuff size should we use?
Hello, please, am I heard? Am I audible? Okay, that's an interesting question. I don't know why somebody wants both arms to be, but definitely there's not been a lot of validated this thing to get the correct one, but you can actually use the thigh and the calf. Research have shown that typically if you're using the thigh and the calf, the BPs are typically 10 to 20 millimeters of mercury higher. So you need to, take note of those ones. But secondly, if you're doing that, so you have to have a very big calf. Of course, we've said that it must be at least 80% in terms of the length of the circumference. So you have to have a very big calf to be able to do that. You can use both the thigh and the calf. As I said, the values are not as accurate as what has been validated for the arms, and even the wrist sometimes do not give you a very accurate one. So with all those ones, you need to be very careful of that. There are times that they talk about you can use Doppler. If you want to be very sure, there are some invasive techniques. There's that one, but of course, you wouldn't want to use invasive methods to be monitoring. But at the hospital setting, yes, you can, and sometimes in Doppler, but you may not get a very accurate one. Probably we may need to do a lot of work to validate and get accurate figures that corresponds to the real figures. Thank you.
All right. And then someone wants to know that doing a health screening, they take the blood pressure of a patient and it records one reading and subsequent readings don't show up, even when they change the arm. I want to believe it may be equipment failure. You may need to change. You didn't state whether you changed the equipment. We want to find out if it has happened to any of you panelists before.
I don't know who is asking those questions, but very interesting ones that are coming through. But there are a few things, especially if you are using the automated, that could give you, if they are involuntary, so have this issues that give involuntary movements. Of course, a signal to have a very some wave to help the automatic this thing to record. So when there are involuntary movements, definitely there will be issues. Of course, if you are dealing with somebody who is very obese and the capsule is not able to help, you may not be able to record well. But one of the things that has also been realized is very thick, stiff arteries. Okay, sometimes, especially for the elderly folks, sometimes you may have some bits of difficulty. And of course, irregular pulse may also have difficulty. If you have irregular pulse, that's why we say that in those instances, You may need the manual. Very irregular ones, you may have challenges in recording. Sheila, I don't know whether you've had experiences like that. Yeah. So these are the few ones that I've seen documented. Yeah.
All right. Okay. Thank you so much. So at the point, we had technical hitches and there was no sound. So I want to apologize for that. There's a comment on that. So I'm so sorry about that. Dr. This is to you. He says that I find it disturbing when a patient is seen at the OPD with BPs of say 230, 120 and is sent to the ER for further management and control. And the patient is sent back to the OPD or sent home on orals without any monitoring in the ER because the physician thinks that there's no end organ damage. And please, is this the new norm? What's your take on this practice?
Okay. So no, it's not the new norm. I don't know the circumstances around which, all that happened, but that was clearly hypertensive urgency and it requires monitoring. So sometimes the history will tell you that it's just because they've not taken their medications for a certain number of period, but those are very high BPs. And so you have to admit and then just observe. Sometimes after their regular medications, it starts coming down. So I would not send home immediately. I would still admit and manage till the BP comes to a safe. So you may still admit on just the regular orals, but at least keep in hospital to.
All right. Okay. Thank you very much. Then he says, there's another question for you, Dr. Tukwefio. What combination of medications will be recommended for resistant hypertension in end-stage renal failure? I mean, you touched on it, so maybe just briefly say it again.
And unfortunately, we see that a lot. But I mean, all the classes I mentioned, so the calcium channel blockers are useful, beta blockers, and then the centrally acting. Here we have methyl dopa, hydralazine is also good. Caution is only expressed for the ACE inhibitors and the ARBs, and then the mineralocorticoid receptor antagonist like spironolactone, of course, because of hyperkalemia, but the nephrologists these days, so the EGF cutoff up to about 20, if I'm not mistaken, for the ACE inhibitors, but sometimes they still cautiously give, provided you can monitor them closely. But we all know that in our part of the world, sometimes repeated BUE and creatinine and monitoring is not, so at that point, I'll say that you may have to refer the patient to a nephrologist, but all the other classes are very useful in managing end-stage renal disease. Thank you.
All right, thank you so much. So, Dr. Nketia, you highlighted on lifestyle medications. In fact, we have a lot of questions on lifestyle modifications, and throughout our CPDs from the beginning of this series, there have been a lot of touch on lifestyle management and how it helps with management of the chronic diseases we are having. So like I told you last time, hold your horses. Our very last CPD is on lifestyle medicine, and we'll get all your questions and everything answered on the 21st of May when we have that CPD. But this question says that which salts are the potassium-rich salts? Is it the same kitchen salt we've been adding to our food? You need to explain what you mean by potassium-rich salt. And it says some patients with very high BPs for the first time, let's say 200, 120 with EGFR less than 5 and ultrasound finding supportive CKD. Patient is asymptomatic to both CKD and hypertension and has no other comorbidities. First, how do you tell whether the BP caused the CKD or the CKD caused the hypertension? Then secondly, for such patients, that the potassium is high, is there a role for ACE or ARBs? If yes, what significant renal protection do we want since the function is already low? So Dr. Tukwefio will take the last part of the question, which is the severe hypertension, EGFR less than 15, and also have CKD, not sure which caused which. Then Dr. Nketia, you answer your potassium salt.
Very interesting. I mean, I think the person was asking this question. We have to do some business together, right? It's a business opportunity for all of us. When you go to the malls and other places, these are imported ones. I'm not actually seeing a local one, but I think that I've heard about the Martin Light salt. There's also the new salt and the salt for life. If you go to, I mean, you can go to the net and import some. Probably, please. I talked about it. So when you bring it down and registering it, make sure that I have a share. But I think there's an opportunity, knowing that these are things that could help reduce BPs, for us to advocate it. I mean, for some of these things, bring it down and market it. But locally, I've not actually seen anybody, but there are imported ones that you can actually go to the mall, request of, or actually buy from online. Yeah.
Dr. Tukefio, the severe hypertension, end-stage renal disease, which cause which? Hypertension cause the CKD, or CKD is bringing your resistance hypertension?
Yeah, so that's always a difficult question to answer, because they tend to be very bi-directional. But this is where our history taking and then investigations help. And so if you go back, depending on how the patient presented, how many years they've been hypertensive and all that, you have an idea as to whether this is hypertension-mediated organ damage, or this patient had a primary renal pathology causing that. So I'll say that it's difficult to immediately tell, but history taking and our labs can help decipher that.
All right, Fam, can we come to you with your 3 questions? NHIS, the cost of the medication, and if irbesartan is readily available.
Okay. First of all, irbesartan is not on NHIS. Yes, it's not on NHIS. But we run access programs for some of the major hospitals like Kolebu and others. So for those hospitals, you can get it at very affordable prices. So with the retail market, the ranges, so we have Approval 150, 300, 155, 150, 10, 305, 310. Then we have the co-approval 150, 12.5, and the 300, 12.5. So for the range, it's between 220 to 330.
All right,
Yes,
okay.
please.
So the range is between 220, 320. But think about it's being cost effective, combination therapy as you see your patient, and then you see how you prescribe for them. So thank you.
Yeah,
So there's a few more questions to go for our panelists. It says that it's very difficult in the district when you have to refer a patient to a cardiologist or endocrinologist, because you have probably reached 4 or 5 medications, but the BPs are still uncontrolled. And they won't go because of financial constraints. What do we do in these circumstances? Before you answer that, you should stay tuned for next week's presentation when we talk about digital innovations in primary care, things like telemedicine and all that. That can be your go-to solution. So let's meet on Tuesday next week as we talk about that. Will be our next CPD. But Dr. Tukefio.
Yeah. So I understand that it can be difficult, and yes, that scenario does exist where patients are on about 5 antihypertensives and still poorly controlled. It's called refractory hypertension. Yes, so it's there, but I would say that it takes a lot to get there, because have you really optimized this patient's medication? Some of the good ones, quote unquote, can be expensive and so not readily available, for example, to the patient. So even if you cannot immediately refer, in fact, some texts say about 6 months, you have 6 months, primary care level, to try and manage things. So I'll say that try and optimize the ones that you can, try and substitute, the good ones for, or the not so good ones for the current ones as much as you can, because it's all about availability and consistency. If you give the patient something that's too expensive and they cannot afford, it's just the same thing coming back. So I would say that to say the patient's on about 5 and poorly controlled, it takes really a lot to get there. So you go back to the history, see if they are doing something else, they are taking some herbal medications or something, and if they are truly compliant. And then if it's still poorly controlled, unfortunately, you have to find a way of screening for secondary causes as well.
All right. Dr. Nketia, it says, do patients with white coat hypertension, when they come every time and the BPs are high, and you tell these patients, madam, your BPs are high, they tell you that, oh, no, my BPs are always normal in the house. Do these patients require treatment at all? Because sometimes it's persistent. They are coming in and every time it's high, but in the house, they are telling you it's normal, or their home BP monitoring are normal. Do these people require treatment?
Okay, thank you very much. I think that when it comes to hypertension, the first thing is that you need to confirm to treat. And that's the first one. But the fact that they are home and their home BPs are normal doesn't mean that indeed it's normal. The machine that they are using at home and all that, is it validated? Is it the correct one? If you're not sure, do ambulatory and be sure. And other thing that I think Atikeshi also mentioned is that we need to do some investigation. They will go into failure. So I think that the first thing is that you must try to confirm. In confirming, you must try to make sure that you are using the correct validated tools. I mean, there are times that you ask the client, look, bring your BP machine. Probably the BP machines at home is giving 115. You come to us to realize that it is not consistent with, it's not been validated. So of course, they will get normal ones at home, but not. And other times too, you realize that they may have other things like end organ damage, and realize that, look, whatever it is affecting this client. And that's why even with elevated BPs, where it's not hypertension, when the cardiovascular risk is high or there are end organ issues, you need to try and break it down. The third one is that you need to also calculate their cardiovascular risk. So depending on the level and their cardiovascular risk, you may need to discuss. It's patient-centered. I mean, it's individualized. What I would do for A might not be the same as B. But when I look at all these things and the discussion goes on, there need to be consideration for treatment if these things are there. Thank you.
All right, thank you so much. The questions are coming. I'll do well to summarize the rest of the question for this last session of questions I'm going to throw to my facilitators. So, is there any benefit for preferentially starting an ARB over an ACE inhibitor? Between these two, which one, is there any benefit for choosing one over the, aside the side effects of an ACE inhibitor in patients with hypertension, or especially in patients with heart failure, hypertensive heart disease? Then there's also a second question where it says, for diabetics with hypertension and no albuminuria, should ACE inhibitors or ARBs still be the first line? Or we can start with calcium channel blockers and diuretic with these people. Okay. Your mic is off. Yes. Your mic is off.
The mic.
I was saying that either or is indicated, you know, aside the side effects, you can use either of them. And then the second question was about
diabetics with hypertension, but no urine proteins.
Yes.
Whether you still have to do an ACE inhibitor for that.
Yes, it's still indicated as first line, because aside reducing the progression, it prevents proteinuria as well. And so it's still indicated as first line for all diabetics. Yeah.
All right. Okay. Thank you so much, Dr. Nketia. I will end with you as answering the last question. It says, please say something about hypertensive emergency and its management. So in 2 minutes, if you can say something about hypertensive emergency.
Also, I'm going to refer those ones to Sheila. I think I'll refer that one to Sheila. Yeah, so that she would guide us with those ones.
So 2 minutes.
Yeah.
Okay. So the premise, we can use the question the panelists asked about somebody with a BP of 210, I think 120, who had come in and was sent home. So basically, hypertensive emergency is when there's evidence of target organ damage, and then urgency is when there's none. And in those instances, yes, you need to bring the BP down rapidly, except in the cases of strokes where you may want to come down gradually. So aside admitting the patients, you can start the parenteral medications. Labetalol is commonly used. Sometimes we use hydralazine as well. And so it's about recognizing the target organ damage. And so bedside ultrasound is very useful. And most of our emergency rooms, at least in Accra, and I'm sure Kumasi, we have it, is useful because then you can identify things like left ventricular hypertrophy, reduced systolic function, and all that. And so in a hypertensive emergency, it's indicated to bring down your blood pressure rapidly. And it's all about history taken and examination. We need to remember to examine the lung bases and all that. So that's what I'll say about hypertensive emergency, the fact that we need to recognize the causes and then be able to bring down the BP to an appreciable level. And typically, once you get to about, I think, 180, 110, thereabouts, you can start adding on your oral antihypertensives.
All right. Okay. Thank you so much. So we want to use this opportunity to you and then Group Ethica Ghana, right, for helping and collaborating with the Society of Family Physicians to bring on this CPD this afternoon. Like I mentioned at the beginning, this is our 4th CPD. Next week on Tuesday, we are going to have a CPD on digital innovations in primary care, the role of telemedicine. So please stay tuned. Look out for the flyer, the link to register for this free CPD, and let's meet again on Tuesday and see how we can learn and improve our primary care in this country. I also want to use the opportunity to tell you about the upcoming programs by the society as we gear up to World Family Doctor Day, which is on the 19th of May, 2026. It's a day that we are going to create awareness about what family physicians do, what a family doctor is. So look out for our media engagement as we do that. We will crown it with our AGSM that is coming up on the from 21st to 24th May, which will be happening at Westin Serene Atlantic Hotel in Takoradi. So thank you so much for tuning in, and I will see you on Tuesday. Have a good evening.